My name is Andy Shannon. I'm an obstetrician based in London. I'm professor of obstetrics in King's College in London. I'm also chair of the Preterm Birth Committee of FIGO, which is why I have this background. But I've been asked today to talk to you about prediction and prevention of preeclampsia. So in the next 20 minutes or so, I'd just like to highlight some sort of new areas in the management, as I'm sure many of you are established and accomplished clinicians and understand the disease very well. So I'm really cherry-picking some interesting points around prediction prevention as illustrated in this slide. And we'll talk also about detection, treatment, and some of the management issues like admission. Now, we're all very familiar with the pathophysiology of preeclampsia. It's undoubtedly related to the placenta, and there's something about the perfusion, reperfusion of the placenta that results in a syndrome of preeclampsia. The thing about preeclampsia is it probably does start early on related to this poor placentation. Eventually, you will get high blood pressure and proteinuria presenting, and not invariably, but that's followed by symptoms which we all know about: headache, visual disturbance, epigastric pain. And then almost invariably, if you have the diagnosis right, a crisis that requires urgent delivery for either mother, to prevent a sort of serious disease in the mother or the baby. And that is pretty reliable. It's often less than 2 weeks, and in preterm preeclampsia may only be a number of days. I think for most of preeclampsia, therefore, there is no symptoms, although you can detect that you are going to get preeclampsia. And some of the new biomarkers I'm going to talk about actually can be measured right from the first trimester to tell us preeclampsia is coming. How we use that in clinical practice is a challenge, and I will elucidate some of those issues. So what about predicting preeclampsia? The thing about preeclampsia is just statistically, it's a low prevalence condition, and therefore even a very good test isn't that great. And that's just a simple statistical quirk. There are a lot of false positives, even in a relatively good test with good sensitivity, specificity, which has been a challenge for us. And this is sort of illustrated in the clinical prediction, where some factors we know are related to the risk of getting preeclampsia. A raised BMI over 30 will give you a 3-fold increased risk. But if you look at the population, because of this low prevalence issue of the disease, actually, many women with raised BMIs will not get preeclampsia, and many women with preeclampsia don't have a raised BMI. So that is the issue. So there has been great interest in finding a marker to try and tell us who gets it, and then help manage. And I think the angiogenic markers have been illustrated really nicely in the literature about their relationship to preeclampsia. And the two to concentrate on are soluble FLT, which increases, and PLGF, which reduces. And various papers over the years have illustrated this, but this nice one, New England Journal of Medicine, has shown how even from the first trimester that something like PLGF is lower than it should be in those destined to get preeclampsia. And once you have preeclampsia, like the black dots here, it's very low. Well, what can we do about preeclampsia prevention? Well, if you are at risk, giving low-dose aspirin is helpful, and various guidelines now, and the one that I'm familiar with is NICE in the UK, does recommend that if you have a risk factor, and if you have a high risk factor like underlying hypertension, chronic kidney disease, autoimmune disease, diabetes, and so on, you probably should go on to low-dose aspirin. Recent evidence suggests that low-dose aspirin isn't so good in chronic hypertension. Just be aware of that. And if you have 2 moderate risk factors, such as it being your first pregnancy or older age, high BMI, you might also like to consider low-dose aspirin, as well as various other things like multiple pregnancy and family history and so on. When to take aspirin, actually, rather curiously, if you take it at bedtime, it seems to have a better effect. If you take a higher dose, like 150 milligrams, particularly if you are obese or slightly larger, that's probably sensible, seems to have a better treatment effect. And across the board, it has benefits not just in reducing preeclampsia, but also probably growth restrictions, small for gestational age, serious adverse outcomes in general. It has the same sort of treatment effect. These initial studies had about a 10% reduction in all these things. Actually, newer evidence. This is actually recommended by FIGO now, as part of the Asprey project, shows that if you give a higher dose, you give it early, stop it at 36 weeks, give it at bedtime, and if you target it to high-risk people, the treatment effect can be much better than this 10%, and actually it can be nearly 90% for preventing early onset preeclampsia. And giving low-dose aspirin now seems to be a sensible decision. What about detecting preeclampsia? We all know that blood pressure measurement varies a lot. It goes up and down. We have different equipment to measure it, and there are some issues that you need to be aware of. So single readings not taken carefully will potentially give you errors, and therefore increasing the numbers of readings you take is a simple way. So we would repeat it, for example, if it's raised, or we would rest the patient and do it again. And this reduces the sampling errors. The automated devices are a bit of an issue in preeclampsia, and they do under-record. And the reason for that is there is an unusual cardiovascular change in preeclampsia compared to pregnancy and to non-pregnant people. You get a big reduction in intravascular volume. You get this very high increase in peripheral vascular resistance. You have this tissue edema, which influences the oscillometry of these blood pressure machines. And the bottom line is these machines under-record. Here's an example of a relatively simple, cheap machine that does well because it is validated, whereas a relatively expensive machine is sort of 20, 30 millimeters lower than it should be. And this is in a woman who's just had an eclamptic fit. And to illustrate this is from one of my studies from Sierra Leone. They sent me this picture of a woman who's got a very high blood pressure, 210, 137. And they said, oh, is this correct on this new machine? Because our ICU machine is saying her systolic's only 160, 112. I'm pretty sure the validated machine is correct. And this error and difference is commonplace. This woman actually went blind a couple of hours later, and I'm sure she had very severe hypertension. We have similar errors with dipstick proteinuria. Here's a single case of a woman where, depending on where in the day you happen to do your dipstick, because of dilutional errors and diuresis that varies according to diet and so on, you can get 2 pluses in some parts of the day, you can get trace in other parts of the day. And of course, the way we've got over this over the years is by taking 24-hour collections, but simply by doing a ratio, a PCR or something, we can get over these dilutional errors. A simple way around this is to use an automated reader as well. And actually automated readers, these PCR sticks are now becoming available. And this is actually recommended by NICE to use automation because we also have errors reading the dipsticks. Don't forget the symptoms of preeclampsia. It is recommended in our UK guidelines that every woman should be made aware of what the symptoms of preeclampsia are. They are severe headache, problems with vision, pain below the ribs, vomiting, swelling, hands, face, feet. Now, of course, all those things can be just symptoms of pregnancy. And I think the key thing is if they are new and different, you should seek advice quickly. If they're persistent, then obviously they should get their blood pressure and urine checked. And of course, now we have biomarkers in this subgroup who have these symptoms that help direct us those that really need attention. And it's sensible advice because seeking care is the first step to keeping patients safe. Now, what about these angiogenic markers? I don't know how many of you are familiar with the rocket curve, but this actually illustrates in one of our studies how PLGF, which is placental growth factor, when you measure it, if it is high, over 100, you have a pretty normal outcome. In this case, this ROC curve is showing that very few people need delivery from preeclampsia in the next 2 weeks if they have a level over 100. Conversely, if the level is under 12, this curve is telling us that the most women are going to need delivery in the next 2 weeks. If you look at it in subgroups of patients, those with superimposed preeclampsia, with atypical preeclampsia, with renal transplants, chronic hypertension, it works equally well. And the red lines and dots show a very low PLGF. Those women on average delivered only about 9 days after they presented. And these are women who are presenting with possible preeclampsia. So they might have headache, they might have slightly raised blood pressure, you just don't know what's going to happen to them. You do the PLGF, if it is normal green range, they go months before they need delivery, and if it's abnormal in the low range, they tend to have a crisis pretty soon. So it's a really great way to triage. And again, if you look at the ROC areas, comparing it to the things we used to rely on to tell us risk, like diastolic blood pressures, urate, the liver function, you can see that PLGF alone is much stronger. If you look at the sort of women you triage, who come into your day units, antenatal assessment areas, about a quarter of women can be ascertained very high risk by this, and maybe 40% or so will be completely normal, and you can send them home and not have to do any extra checks. There are 2 tests that have been recommended by NICE originally. There's now a 3rd one by Polk and Elmer, but this one by Quidel and Roche are used, have been used over the last few years. You can see that one is a ratio of soluble FLT to PLGF, and simply if you have a low PLGF and a high soluble FLT, as your ratio gets higher, you're more at risk. Don't worry too much about the details, because the prediction depends largely on the study they were performed on. But for the Roche test, PLGF alone is not as good as SFLT PLGF ratio, which is why they use the ratio. So that's kind of explains them. But we've done some studies comparing all the current ones that are available in the UK, and the bottom line is they're all very similar. So in these studies, when we compare the Roche, the Quidel, PLGF tests, that they're all the same. And you've got to remember different values though for different tests, and a ratio of 38 is what matters for the Roche test, and the levels over 100 and under 12 is what matters for the Quidel test. Now, I don't know whether these tests are going to become available where you work, but they've been introduced whole scale now throughout the NHS, and we've introduced them into our protocols where we say, use the test. When we've done clinical trials, and this was published in the Lancet, we diagnosed preeclampsia earlier, and actually there is reduced morbidity associated with the use of the test. And these slides just show how there is less severe problems when we use the test. So going back to these angiogenic markers, when can we use them? We can use them in normal pregnancy to tell us who to give aspirin to. Perhaps their most important use is people who are hypertensive, and we're not sure whether they're going to need delivery or not. We're still not sure if you have established disease, if they have a role, and there's current research to look into that. I appreciate that these angiogenic markers may not necessarily be available where you work, but I think they particularly have a role in low-income settings where morbidity mortality is much higher. Some of my research is now looking at the role of using PLGF point of care, which is much simpler and cheaper in Sierra Leone, and I think this is a space to watch for the future, and I just thought you might be interested. Now, what about managing the condition? Because the aspirin will help in preventing it, but the only real way to prevent morbidity mortality is identify the people at risk, watch them closely, and timely delivery. And therefore, the management issues are important. And while we're waiting for the disease to evolve and become a crisis, we can keep people safe with antihypertensive therapy and anticonvulsant therapy. In the UK now, preeclampsia has almost disappeared as a cause of maternal death. It's still a big problem with premature babies having to be delivered because we haven't actually got a cure for the disease. Perhaps aspirin helps, but judicious management and careful surveillance and then acting appropriately at the right time is what keeps people safe, and it works. And now in the UK, only 1 in a million women will die. And for many decades, it used to be one of the commonest causes of maternal death, and it is now the least represented cause on the categories in the confidential inquiries into maternal death, which is a great success story. And you can see that in the 1950s, we had this huge improvement, but since the 80s, there's been a fairly steady level of deaths from preeclampsia. And suddenly in the last couple of years, last couple of decades, maybe a decade or so, things have got better. Now, I want to illustrate the fact that preeclampsia, although when managed well, the death rates are incredibly low. So in the UK, literally 1 in a million, they're actually 15 times higher in the US. And I think those differences are explained by the fact there isn't universal healthcare provision in North America, and that really illustrates why it's so important that everybody has their blood pressure and urine checked. But you can see that the burden of disease here is in low-income settings, particularly in Africa and Asia. Now, if you look at when the therapies that we all know and love came into act in the UK, they didn't really have a big impact on maternal mortality, magnesium antihypertensives. And I think, although they're important, I think it's this sort of judicious timing of delivery that's probably the most important way of saving lives. And obviously, mag sulfate will keep people safe, as will antihypertensives. And it's probably more basic things around, good practice and surveillance that has had the real impact. This is to show how our guidelines introducing aspirin and these more judicious managements properly have impacted on outcomes. And treating blood pressure is important because it prevents cerebral deaths. But the thing that really has prevented deaths in the UK is good fluid management. And we know that these patients have leaky capillaries. They are susceptible to getting ARDS, pulmonary edema, adult respiratory distress syndrome. And by making sure that people aren't overfilled in this sort of obsession with keeping the kidneys going and so on, so controlling fluid intake, we've got rid of the pulmonary deaths from preeclampsia. We still have to treat blood pressure a little bit better to get rid of those. When you treat blood pressure, you've got to remember you are treating a threshold. You also need to aim for a target. What is the evidence? Yes, it will halve the risk of getting severe hypertension if you treat moderate hypertension. And the best agents are beta blockers and calcium channel blockers, which are probably more effective than methyl dopa. What about eclamptic fits? We know from the MAGPIE trial that if you give magnesium sulfate to women with established preeclampsia, it will halve the risk of you having another eclamptic fit. It translates into 11 fewer fits per 1,000 women treated. And there's a trend towards reduced mortality as well. So there's no doubt that it's a good thing to give magnesium sulfate, but it doesn't mean that woman shouldn't be delivered. I think, generally speaking, if you're giving mag sulfate, you should be delivering the woman. The other thing to remember about magnesium sulfate is it does have this benefit in reducing morbidity in premature babies. And certainly before 32 weeks, it is highly recommended that babies should have magnesium sulfate, even if you don't have preeclampsia, in reducing cerebral palsy, to reduce cerebral palsy and motor dysfunction. And the regime for giving mag sulfate, one, don't give it unless you're planning delivery, would be my advice. You probably should give it about 4 to 6 hours before that delivery, if you have the opportunity to time the delivery, which you often do in preeclampsia. But don't delay the delivery if you haven't given it. Just start giving it, because it probably has an immediate benefit, and you can read the regimes online quite easily. You can see here that there is definitely a benefit in terms of reducing death and cerebral palsy if you kind of have gone more than 24 hours, and should you repeat it? Probably we haven't yet got enough evidence for that. Now, finally, I just want to talk about timing of delivery. We know that if you have established preeclampsia and you've got the diagnosis right at 37 weeks, you're better off being delivered. Before 34 weeks, you're probably better off waiting and just waiting for a crisis to justify, get the maximum maturity. But there's this uncertain area of 34 to 37 weeks. And of course, if you deliver the baby, it may be immature, but you will remove it from a hostile environment where it's potentially going to have abruptions and be subjected to HIE and asphyxia and even intrauterine fetal death. Just those of you who follow Twitter, please do have a look at my Twitter feed of evidence. But just to remember that donor eggs in IVF is a potent cause for preeclampsia. I really like to finish just on this slide. If you've had preeclampsia in the past, you've got a pretty good idea of your chance of getting it again is related to the gestation at which it happens. And so overall, about 1 in 6 get it, but it's about 1 in 4 if you've had early onset preeclampsia, and as bad as 1 and 2, it's before 28 weeks, and I find that evidence really quite useful. Thank you very much for your time. Just to thank all the people in my team from all over the world now, where we find that preeclampsia is one of those conditions where you really can make a difference relatively cost effectively, because you can identify a problem and you can do something about it. Much easier to treat in terms of than PPH and sepsis and so on, which are the other big maternal mortality killers. Anyway, thank you very much for your time. If you're interested, have a quick look at this Lancet editorial, which I wrote with my colleagues Lucy Chappell and Marcus Green, and it just distills the elements of how we make an impact in bringing mortality down, and really kind of illustrates the great success we've had in the UK. I'm going to just finish there. Thank you.